So welcome to this CPC Connecting Generations webinar. Our speaker for today is Bruno Masquelier, Professor of Demography at the Catholic University of Louvain. Bruno is also a member of the Technical Advisory Group of the United Nations Interagency Group on Child Mortality Estimation and a member of the World Health Organization Task Force on Age-Specific Mortality Estimation and life table computation. His research interests cover mortality trends and youth mortality in low and middle income countries, and today he'll be presenting research on the shifting age and sex patterns of premature mortality from ages 5 to 25, a systematic analysis of vital registration, surveys and censuses from 1990 to 2021. I'll hand over to Bruno now to get started.
Okay, thanks. Thank you very much for this invitation to present this work. I'm very glad and honored to give this talk, and I would like to thank Susan and Sarah for the invitation. As you know, we've made unprecedented progress in the fight against early childhood mortality. If you go back in time, not so long ago, in 1990, the world saw 13 million children dying every year under the age of 5. And this number has dropped to about 5 million deaths in 2021. So this progress is attributable to many factors: a reduction of extreme poverty and hunger, increased coverage of interventions, improved sanitations, and also a strong political commitment. Under 5 mortality was an explicit target of the Millennium Development Goals, and it's still today a target of the Sustainable Development Goals, or the SDG. The SDG called for all countries to reach an under 5 mortality rate as low as 25 deaths per 1,000 live births by 2030. And neonatal mortality should fall below 12 per 1,000. We know now that 122 countries have already achieved the SDG under 5 mortality target. 20 countries are on track to achieve it by 2030, and 53 countries have to accelerate their progress because they're not on track to achieve this target by this deadline. But progress is continuing. And so we have this very strong focus and political commitment on under 5 mortality. And we need to make sure that this focus is not made at the expense of older kids and adolescents and youth. And those kids should not be left behind. And I think this is a growing recognition around the need for connecting, recognizing the interconnectedness of maternal, newborn, child, and adolescent health. I'm going to just take 3 examples here. The first is the Global Strategy for Women's, Children, and Adolescent Health, which has a target related to adolescent mortality. Another example is WHO and UNICEF calling 2 years ago for redesigning health programs for children and adolescents by taking a life course approach. And a third example is the Lancet, where a series of papers were published last year on optimizing child and adolescent health and development. And this series look at this window from 28 weeks of gestational age up until the age of 20. So again, taking this life course perspective. So there is a growing need and a growing recognition of, looking at age-specific mortality, but then we need to improve the estimation approaches as well. So in this presentation, I would like to focus your attention on 3 key questions. The first one is, what are the recent trends in mortality between the ages of 5 and 25? And how do they compare with mortality under the age of 5? The second question is, what about inequalities across countries or between countries? Have they widened or have they narrowed since 1990? And then we're going to look at inequalities within countries in this particular age range. Have they reduced or have they accentuated since 1990? So I'm going to base this presentation mostly on estimates from the UN IGME and DHS data. So the UN IGME is the UN Interagency Group for Child Mortality Estimation. This group is led by UNICEF, and it includes members from WHO, the World Bank Group, and the UN Population Division. It was established in 2004 to monitor progress towards the achievement of child survival goals. At that time, MDG targets, and now the SDG targets. And in recent years, it has expanded the scope of its estimation work by focusing on mortality beyond the 5th birthday to include adolescents and young people up to the 25th birthday. And I was very lucky to contribute to this work as a member of the technical advisory group. So the estimates that I will present today were prepared on behalf of the UN IGME. I will more specifically use 4 different papers that we published over the last 5 years. One paper on children age 5 to 15. So sometimes you'll see 5-14, but this is to be understood as completed 14th. It's always from the 5th to the 15th birthday, and then the 15th birthday to the 25th birthday. We have also published recently a paper on under 5 mortality, including with projections up to 2030. We have one paper on mortality in youth age 15-24. And we published this year, a couple of months ago, a paper on the sex differences in mortality across the first 25 years of life. So please bear in mind that this is very much a joint work with many great colleagues involved from the different agencies. And if you're interested in the input data and the final estimates, they are all available online at childmortality.org, which is the website of the UN IGME, where you will find estimates for your country, for all the different age groups, including by causes of death. And in some age groups, there is a breakdown at the subnational level. So for the last part of the talk, I will then focus on within countries inequalities, and I will present some very preliminary and unpublished results from demographic and health surveys using DHS data. So first, how were the estimates developed? So we will focus here on 2 key probabilities of dying, 10q5 and 10q15. 10q5 is the risk of dying of a child age 5 dying before age 15, 10q5. 10q15 is the risk of an adolescent age 15 dying before age 25. So what are the data sources that we have on those 2 key probabilities? Over the recent years, we have built 2 databases with around 8,800 country year data points for each probability from various sources. We've also disaggregated those estimates by 5-year age groups and by sex. And so we have basically 4 types of input data. First, we have vital registration data. That covers only 28% of the population age 5 to 25. We use data from the Human Mortality Database and data from WHO Mortality Database, which are both publicly available. Then we have estimates from some countries where the vital registration systems are not comprehensive to cover the national level or have a different setup. And this is India with the simple vital registration system, South Africa with the rapid mortality surveillance, and a couple of other countries. And then we use nationally representative sample surveys. We use DHS, the demographic and health surveys, UNICEF mixed surveys, and WHO World Health surveys. And from those nationally representative sample surveys, we extract either the full birth histories or the full sibling histories. I'll come to that in a minute. So most of you are familiar with the full birth histories. We're asking, interviewers are asking women of reproductive age about their children, their age at the survey, and if diseased, the age at death and time since death, and so on. And so we are able to use a direct estimation approach because we know the number of deaths by age and period, and we can divide them by the exposure. And so we used a stratified jackknife approach to compute the confidence intervals around the estimates. And we also changed the reference periods to optimize to have as many periods as possible from one given survey based on the coefficient of variation of the estimates. And then finally, we also extract data from recent household death So in many censuses, household heads are asked about whether there have been any death in the last 12 months by age and sex. And so if we divide the number of deaths by age and sex by the population enumerated by age and sex, then we can come up with an estimate of the risk of dying. So all those estimates, they have uncertainty estimates associated with them. So just briefly, maybe some of you are not familiar with the sibling survival histories. So as the name suggests, in the sibling histories, women aged 15 to 49 are asked to list all their siblings born to the same mother by birth order, and then report on each siblings the sex, the survival status, current age if alive, age at death, and years since death if deceased. So this is basically similar to a birth history, but a birth history of the mother of the respondent. And so we use those sibling histories to estimate mortality above age 15, because the birth histories, they don't give us the information we need to estimate mortality in adolescents and youth. We use birth histories for mortality below age 15, just as for under 5 mortality. So unfortunately, we cannot directly use the estimates and come up with a smooth trend across those estimates, because we know that many sources need to be adjusted, and some needs to be excluded. So vital registration data cannot be used in many countries because we simply don't have data. And in several countries, such data need to be adjusted. On this map, I've plotted the proportion of deaths that are registered and reported in the WHO database, calculated based on what demographers call death distribution methods. So basically, we're comparing the age distribution of death with the age distribution of the censuses, and this is computed for the last intercensal period in each country for which we have data. And what you see is that sub-Saharan Africa, which today represents 15% of the world population, is not represented in this database, with a few exceptions, such as South Africa. We also need to note here that India and China have specific systems to compensate for the lack of a national full-fledged system. This is the sample registration system in India and the disease surveillance points in China, respectively. So what we do is we exclude the VR, vital registration data, if completeness is below 80%. We adjust if it's between 80 and 95, and we include without any adjustment if it's higher than 95. And we compute the completeness estimates by sex, because then we will disaggregate the estimates by sex. Surveys also need to be carefully looked at, because we want to avoid a situation where you fit a trend line on data that are affected by reporting errors. So you can imagine that if you ask respondents about siblings in context where fertility is quite high, you may have some omissions and misreporting errors about ages. You could forget some siblings, you could add a cousin and so on. So we need to look carefully at the sibling survival histories. So before fitting the model for mortality above age 15, we excluded some surveys. And for this, we looked at the plausibility in the age patterns of mortality. What we did was comparing 10Q5 with 5Q0, the under 5 mortality, based on data that we knew were of high quality. So we used the human mortality database. Those are the gray dots that you see here. We use estimates from health and demographic surveillance systems. Those are small populations that are followed prospectively. And we use data from the SRS system in India and the vital registration in Mauritius. So we get a cloud of points. And from this reference database, we use a log quadratic regression model to predict, for a given level of under 5 mortality, what the expected level of 10Q15 we should see. And if the survey estimates were below the lower bound of the 95% prediction intervals, we would disregard the survey. We would consider that data is not of sufficient quality, so we will leave that out. This represents about 12% of the surveys. And when we model a mortality in children aged 5 to 15, we align with the exclusion criteria used for under 5 mortality. So the United Nations IGME estimates are updated annually. So when a new survey comes in, the colleagues at UNICEF, they look very closely at the data, and they decide based on a variety of data quality checks whether to include or exclude the survey from the model fitting. So we will use the same decisions for children aged 5 to 14 because we use the same kind of birth histories. It's also very important to say that when the estimates are almost finalized, those draft estimates are sent to each country. So they are sent to a representative of the country at the Ministry of Health or the National Statistic Office to ask for additional data and ask for comments on the trends in mortality, including for those age groups. And that allows countries to provide new data or to discuss maybe why this data is excluded or included. Now, in terms of the model itself, we used a Bayesian B-spline bias reduction model. So it's called B3 for those 3 Bs. And the model was developed by Leontine Alkema and colleagues for under 5 mortality. But we apply it for the probabilities 10q15 and 10q5. And the model treats observation of those 2 probabilities as the product of the actual risk of death and an error multiplier. And this multiplier will vary depending on the data source. So we expect errors to be smaller with vital registration data and larger for surveys, for example. And the trend in the log of 10q5 or the log of 10q15 will be modeled using B-splines. And countries can exchange information on the degree to which the log of 10q5 or 10q15 deviate from a linear trend. So it's important to note that there is no information exchange about levels. It's about the way you can deviate from a linear trend. And then biases in surveys and censuses will be estimated based on how observations are consistent, coming from different sources for the same period using a hierarchical model. And so overall, the model will take into account stochastic standard errors for vital registration, biases in data series in the surveys estimates, and possible outliers. So we're combining sampling and non-sampling. We deal with both sampling and non-sampling. And the estimates are updated annually. And they are now produced for 200 countries. So we have estimates from 1990 to 2021. So to make sure that we could use a model that was originally developed for under 5 mortality and apply this model to other age groups, we ran out-of-sample validation exercises. So the idea there to assess the model performance is that you build a training set by eliminating the recent data. You pretend that you don't have access to, let's say, data after 29, for example, in this graph, so that you leave out about 20% of the data. And then you use this training set to generate new estimates. And those estimates would be obtained if more recent data were not available. And then you'll compare the estimated values with the observed values based on the most recent surveys, for example, and also with the mortality trends that you obtain from the full database. And overall, the validation measures, they indicate that the model works well for mortality in those 2 age groups. Of course, there is still scope for improvements, but we're pretty happy with the way it works for now. Okay, this is just an illustration of the data inputs and the final estimates in red for the US and Senegal. Final estimates are in red with the uncertainty intervals. Those are 90% uncertainty intervals. And you see that in the first case, we follow the vital registration line closely. And in the second case, we reconstruct the trend based on surveys. And you see that as a result, there is more uncertainty around the final estimates. But in Senegal, we're pretty happy that we have a lot of surveys that we can use. Okay, so to be complete, I should say that in about 30 countries, there are not enough data points to use the B3 model based on VR, surveys, or censuses, or the country is too small and there is too much variability in the vital registration data. Think of small islands, for example. This represents only 5% of the population considered. So it's a limitation, but it's only about 5%. So what do we do for those countries? we use again this relationship between 10q15 and 5q0, or 10q5 and 5q0. We fit a linear regression across this by region, and we use the regional coefficients and the under 5 mortality estimates from UN IGME to derive an estimate for older children and adolescents. So there is clearly room for improvement here, and we will explore other avenues in the future because the data limitations might continue in the future. Okay, this is about the data and the methods. Now let's look at the results. This map shows you the latest estimates of the 10q5 probability, so in older children and young adolescents. And it shows you a very unequal world, with risk ranging from over 30 per thousand in Niger to less than 3 per thousand in many high-income countries. Globally, the risk of dying between the ages of 5 and 15 was 6 per thousand. So you may think that's not much. Indeed, that's not much. Under 5 mortality is 38 per thousand live birth. And here we're considering a period of 10 years, while under 5 mortality obviously is about 5 years. So that's not much, but it still corresponds to 0.8 million deaths a year. And as we will see, most of those deaths are from preventable causes. So we definitely need to focus on this million deaths a year, which could be avoided. Let's look at the regional and global estimates of the risk of dying on top and the death at the bottom in millions. I mean, this is a lot of information, but you can note the enormous progress made in Central and South Asia. So this includes India, where mortality in this age group has been divided by more than 4. And you see much slower progress in sub-Saharan Africa. It's about a reduction of 57%. At the same time, the number of deaths has fallen only slightly in sub-Saharan Africa because the number of children has more than doubled over the same period. And that translates into a growing concentration of death in this age group in sub-Saharan Africa. Today, as much as 58% of all these deaths occur in sub-Saharan Africa, but the region hosts only 27% of the population of this age group. So we see the growing concentration of mortality in this age group in sub-Saharan Africa, and this is also something that is appearing when you look at under 5 mortality. Now we move to children, adolescents and youth age 15 to 25. And again, you see the mortality is highly concentrated in sub-Saharan Africa, here in Central Africa, but you also see Venezuela and Afghanistan here standing out as high burden countries. In Venezuela, this is due to the crisis. Globally, the risk of dying was 11 deaths per 1,000 and 5 deaths per 1,000 before age 20. This again translates into 1.3 million annual deaths, of which 0.6 were between the ages of 15 and 20. And again, most of those deaths are preventable. So the same figures here, same table with the risk of dying on top and the death at the bottom expressed in million for those 2 years. And what you can see there is that the probability of dying in this age group has declined by about 36%. But because the population at risk increased globally by 22% over the same period, the annual number of deaths has only slightly declined. We're moving from 1.7 million in 1990 to 1.3 in 2021. And there are some regions, if you look at sub-Saharan Africa, where the number of deaths in youth has actually increased. And this is because the mortality decline has been outpaced by population growth. So again, we'll see a concentration of mortality in sub-Saharan Africa in this age group as well. So this is not coming from the papers that I listed above. This comes from colleagues at Johns Hopkins using the United Nations Interagency Group estimates as their mortality envelope, but they disaggregated that by codes. They don't produce estimates up to age 25, so this is only from age 5 to age 20. If you're interested, they just updated those estimates today. And if you go on childmortality.org, you'll see the latest estimates. I plotted this here because I wanted to highlight that a large proportion of death in the age group 5 to 20 are preventable. Globally, if you look at the leading causes of death, what do we have? Road traffic injuries, about 8%, neoplasm, 6%, malaria, 6%, drawing, 5%, diarrhea, 5%. And we do have cost-effective and life-saving interventions for diarrhea and malaria. And we can also, work on improved safety, road safety regulation and enforcement, and specific interventions to prevent drowning and reduce violent mortality in this age group. So what's needed is a set of age-specific, sex-specific interventions. And what's interesting with this age group is also that you can think of a package of health services that could be effectively delivered through the school systems. Because most of the children aged 5 to 19 and adolescents, they are attending school. So you can think of the promotion of and the distribution of insecticide-treated bed nets, school meals programs, healthy lifestyle education, and so on. They can be delivered through the school. So this is a very key age group on which you can, work to reduce premature mortality with key specific interventions once they have been identified. So now we've been talking about under 5 mortality, 10Q5, 10Q15. Let's put everything together and look at 4 probabilities of dying here. 1Q0, infant mortality, 5Q1, child mortality, and then 10Q5 and 10Q15. And this is for the different SDG regions ordered according to the level of mortality. And what you see is that age patterns of mortality, they vary greatly from region to region. In the low mortality regions, such as Europe and North America, we have this distinct U shape. And that means the probability of dying, 10Q15, is now the highest. And in all regions, except sub-Saharan Africa, mortality in young people aged 15 to 25 is now higher than between the ages of 1 and 5. And this is also true globally. So when you think about child mortality, if we define child mortality as the risk of a child age 1 dying before age 5, we are now globally at 10 per 1,000, but youth mortality is at 11 per 1,000. And I think this is a moment to update our perception of what premature mortality is. Increasingly, youth mortality will account for an important share of mortality. If you look at the country level, in 33 countries, youth mortality is now even higher than under 5 mortality. And in the future, a growing number of countries will see youth mortality exceeding under 5 mortality if current trends continue. So I think we really need to start thinking about shifting our perception of what premature mortality means. This is, of course, a reflection of slower progress in reducing youth mortality. You can see that when you compare 1990 here with 2021, you see this U shape is becoming more prevalent in many regions. Under 5 mortality declined by 59% during this period, whereas mortality above age 5 until age 25 declined by 34% only. And this is why you see this U shape emerging more in some regions. We can look at this more precisely using annual rates of mortality reduction, expressed here as percentages. And we will consider 3 decades. So if you look at under 5 mortality, 5Q0, you see this clear acceleration between the 90s and the following 2 decades, and perhaps, and this is very worrying, a slowdown since 2010, if we believe point estimates. Between the ages of 5 and 10, the pace has been, steady. It has remained over 3% a year since 1990. And I think we should try to understand why mortality declined in children aged 5 to 10, despite not being specifically targeted by health interventions. This might be due to spillover effects of the fight against early premature mortality. But we should look more closely at the linkages between mortality and nutrition, for example, in this age group. If you move to older children, you'll see that we have made less progress between 10 and 20 years, and there is no sign of changes in the pace of decline. And beyond 20 years, progress has been even slower, with the possible exception of the decade from 2000 to 2010, And this is probably due to the scale-up of antiretroviral therapy, but this needs to be looked at more closely. But the main point is that mortality decline much slower in the older age group than in infant and child mortality. Okay, speeding up a bit, looking at the annual rates of the reduction by age here, by country, enables us to assess whether there has been a reduction in inequalities between countries. We look here at, on the y-axis is the risk of dying in 1990, and on the x-axis, and on the y-axis you have the annual rate of decline over the whole period for all countries, and the size of the bubble is the population size of the respective age group. At less than 5 years, you see a certain trend towards convergence, but the drop in mortality has been particularly rapid in countries that had an intermediate position in 1990. This is the case of China in red. The annual rate of decline in under 5 mortality in China was 6.6%. This is staggering. And then between the ages of 5 and 10, high mortality countries such as India in yellow, the large bubble, and Ethiopia, the green bubble, they are catching up with very impressive rates of reduction. If you look at young people aged 10 to 15 or 15 to 25, you see less of this catch-up. And you see many of the countries with particularly low rates of decline of less than 2% per year. Orange here is Latin America and the Caribbean. And this is the region with the slowest rates of decline in adolescent and youth mortality. And as we will see later, this is also the region with the slowest rates, the highest sex ratio of mortality, the highest male to female mortality. And I think this is due to violence. If you look at cause-specific mortality, it is estimated that injuries caused more than half of death in the age group 5 to 19, compared to only a third globally. So the slow progress in reducing youth mortality in this region is probably due to the importance of violence there. This is looking at age group 20 to 24, and here we tend to see more convergence. So when looking at the annual rates of decline in relation to the level at the start of the period, we're looking at what economists call beta convergence, this process where high mortality countries are catching up because they're making faster progress. But we can also look at sigma convergence, this process of reducing disparities. And here I plotted 4 different metrics: the dispersion measure of mortality, the tail index, the Gini index, and the coefficient of variation. And I related the metrics to the level observed in 1990, so we can compare the trends over time. And what you can see here, all those metrics are weighted by population size, is a clear convergence between countries. And the convergence is very rapid between ages 5 and 10, more rapid, surprisingly, than in children aged less than 5. This is surprising because we could expect more convergence in this, under 5 mortality, where there is a lot of health interventions. We see slower convergence in children age 10 to 14 or youth age 20 to 24, and even slower convergence in adolescents age 15 to 20. So this deserves more research. Why has mortality in children age 5 to 10 converged more rapidly? We have a lot of investment in a few health interventions around newborns and young children. Think of prenatal care. You can think of skilled attendance at birth, malaria control, HIV prevention and treatment, immunizations, and so on. I would expect this to drive convergence in under 5 mortality. So now, last points, we have looked at disparities between countries, but we can also look at disparities within countries. First, by sex. So we have just published this paper where we disaggregate the estimates by sex using a Bayesian hierarchical time series model, where we capture the relationship between the total mortality level and the sex ratio. If you think of mortality, usually what we see in under 5 mortality is the sex ratio increases when mortality declines, because mortality declines faster in girls. And we have observed the same pattern above age 5, from age 5 to 15 and 15 to 25. So we are able to compare the expected sex ratio that you can see here in green with the observed sex ratio that you can see here in red. And in some countries, such as Australia, there's a good match. And in other countries, such as India, we have significant deviations. In India, the sex ratio, so this is male to female, is much lower than expected. So we use this relationship to compare the country-specific observed sex ratio with the expected sex ratio given the level of mortality. So rapidly on those maps, you see the sex ratio in under 5 mortality from age 5 to 15, and 15 to 24. And what I would just like to mention here is that the sex ratio increases with age. It is 1.13 below age 5, 1.16 from age 5 to 15, 1.65 above age 15. And also we see significant deviations in some countries. So when we compare the observed and the expected sex ratio, we see a disadvantage of females versus males compared with countries with similar mortality in 5 countries below age 5. This is Bangladesh, Egypt, India, Iran. And you can think of this as reflecting discrimination against girls. We see this situation in one country only between age 5 and 15. This is Suriname, but it's a very small country with few excess deaths. And we see that again in 13 countries between age 15 and 25. This is Bangladesh, again, and India. So again, a reflection of discrimination against girls, but now above age 15. What's interesting is we found a reverse pattern in one country below age 5, so Vietnam. This is a disadvantage of males versus females, and 8 countries in the ages of between 15 and 25. And this includes Brazil and Mexico. So our interpretation here is that South Asia is seeing progress in reducing mortality limited due to discrimination against girls in nutrition and healthcare. But we also see excess mortality in adolescent males in Latin America. And this is probably reflecting the disproportionate exposure to violent mortality in males. Checking the time, I have a few minutes to present the disparities by education and so on. Tons of studies have focused at disparities within countries in under 5 mortality. This kind of plot, you may have seen that many times. This is under 5 mortality by type, level of education of the mother in children under the age of 5. The reference here is the the circle in green, no education, higher mortality. And then you see, when you see significant differences, you see the colors, triangles and squares. If you take the ratio of mortality in children whose mother have no education, divided by mortality in children whose mother have secondary or higher education, the median ratio within this set of 50 or so surveys, DHS, where we have birth histories and sibling histories, you'll end up with a ratio of 1.7. And you see significant differences in 39 surveys. But what we haven't not looked at, we have never looked at all those disparities extend above age 5. And if you do that by education, you get this picture. Fewer cases where you see significant differences. But when you look at the median ratio, we are at 1.9. So we do see significant differences in, large differences, even if they're not significant, in many surveys as well. And when they are significant, they go in the same direction. And if you look at older adolescents, so here it's 15 to 20, you also have a median ratio of 1.7. So I'd like to save time for the discussion, but I will very quickly go through those same plots for urban, rural, and wealth index. Before that, this is when I do the same analysis, but putting all surveys together, not the latest survey as you've seen before, to check whether the disparities have changed over time. There is no clear sign that they have reduced. The ratios tend to reduce slightly over time. Urban, rural. Mortality is much higher in rural areas, a median ratio of 1.4 below age 5. 1.6 between age 5 and 15. So again, we do see disparities in survival. and 1.1 above age 15, maybe a sign that disparities are smaller when you move to older age groups, and that might make sense. Again, no sign of reduction in those disparities. Last set, wealth index. The median ratio of mortality in the poorest quintile above the richest quintile is 1.5 in under 5 mortality, with many cases of significant differences. It's 1.8 in children aged 5 to 15. Again, fewer cases where we do significant differences, but it's also because mortality is more uncertain in those in this age group. And finally, 1.3 above age 15. And again, no clear sign that the gaps, the equity gaps, have been closing over time. It's pretty stable over time. So to sum up, I'd like to insist on the fact that in 2021, 1.4 million children and adolescents died between the ages of 5 and 20. 5 and 20. I should have updated that up till 25. But they died mostly due to preventable causes. The speed of decline has been slower than in children aged 0 to 5, with no clear sign of acceleration in the latest decades. In all age groups, the sex ratio of mortality has increased over time, and this is due to faster gains in survival in girls. But we have seen that excess female mortality persists in some countries. And I think it's important to note that equality does not mean equity in this case. We should not expect mortality to be similar among boys and girls because biologically we're different. And then cross-countries inequalities have reduced since 1990, with a greater convergence in children aged less than 10 than in adolescent and youth above age 10. But within countries, disparities in the risk of dying are well documented in young children. They have not really been analyzed in older children and adolescent youth, but they seem to be also observed, and they deserve our attention. And finally, there is very little evidence that within countries inequalities have reduced recently. So my key message here is we should focus more on older children and adolescents. We should improve the estimates of mortality in those age groups. We should understand better what are the main drivers of mortality decline in these age groups, and what are the main risk factors. And we should recognize that each age group is sensitive to specific health interventions, and understand what interventions are needed for each age and each sex, and also what role schools can play as delivery platforms. And we should move beyond this widespread belief that returns on investment in health interventions diminish with age. That's not true. If you invest in the health and well-being of older children and adolescents, you get returns on the adolescent population today, but you also get returns on the decades to come when they reach adulthood, and you get returns when also they benefit the next generation. So thanks for your attention, and I really look forward to your comments and questions.